So our next topic today is lymphocytes, reactive versus neoplastic. So lymphocytes are the cells of the body that respond to foreign antigens. Small lymphocytes range in size from 9 to 12 microns, while large lymphocytes range from 12 to 16 microns. Small lymphocytes have a round nucleus occupying about 90% of the cells. The chromatin is dense and the cytoplasm is basophilic. And here's a nice example of a small lymphocyte. You can see the nucleus is approximately 7 microns in diameter. So large lymphocytes have more cytoplasm and usually contain 5 to 15 small eosinophilic granules. They are a subpopulation making up 5% of the lymphocytes seen in normal blood. So I'm afraid I must apologize because this is not a very good image of a large lymphocyte. They don't usually have these cytoplasm flowing like this. But once you've made this workshop set in concrete, it's a lot of work to get rid of it and place it with a good one. But that's a large lymphocyte. We don't see only, well, as I said, 5 to 15% will be on a normal blood film. So lymphocytes consist of distinct subsets that are quite different in their function and protein products, even though they appear morphologically similar. There are 3 classes of lymphocytes. The B lymphocytes. These are derived from the bone marrow and are the only cells capable of producing antibodies. The antigen receptors of B lymphocytes are membrane-bound forms of antibodies. Interaction of antigens with these membrane antibody molecules initiates a sequence of B cell activation, culminating in the development of plasma cells that actively secrete antibody molecules. T lymphocytes. These arise from the bone marrow and then migrate to and mature in the thymus. T lymphocytes are further divided into functionally distinct populations. The helper T cells are the CD4 cells, and cytotoxic T cells are CD8 positive. T cells do not produce antibodies. Their principal function is to regulate all immune responses to protein antigens and to serve as effector cells for the elimination of intracellular bacteria. The large granular lymphocytes, or the natural killer cells. These lymphocytes do not express markers of either T or B cells and were initially called null cells. Natural killer cells are capable of lysing virus-infected cells as well as tumor cells without overt antigenic stimulation. So now we're going to move on to reactive lymphocytes. Now I might say at this point in time that sometimes people use the incorrect term. They call them atypical, and atypical should never be used, ever. According to the ICSH, atypical is finished. So always think of these lymphocytes as reactive. So in reaction to viral infections, when there is antigen recognition, the CD8 cytotoxic lymphocytes are attracted towards the antigen target and commence to produce cytokines. Activated CD8 cytotoxic lymphocytes are increased in size and have flowing basophilic cytoplasm. The nucleus is enlarged and the chromatin fine with 1 or more nucleoli. And I've listed here for you some of them, or probably the majority of disorders where you see reactive T cells. So infectious mononucleosis, cytomegalovirus, toxoplasmosis, viral hepatitis, dengue fever, measles, chickenpox, bordetella pertussis, and lymphocytosis of acute infection. And Bordetella pertussis is in italics because it is actually not a viral infection. It is a bacterial infection. But most of the textbooks will refer to the lymphocytes in Bordetella pertussis as being reactive. So just concentrate on the lymphocytes here. The red cells are not very good in this particular image, but these are the reactive lymphocytes of infectious mononucleosis. So you can see that the nucleus is quite pleomorphic. The cytoplasm is increased. It's very basophilic. And often when you look carefully, the actual cytoplasm border is quite dark blue with the Romanowski stain. Of course, all these films are stained with the Romanowski stain. This is an example of a cytomegalovirus, very similar to that of infectious mononucleosis. Again, this is another example of 3 reactive lymphocytes in somebody who has got the cytomegalovirus infection. This is an example. These are examples of Turk cells. This is a case of a patient with viral hepatitis. And the Turk cells are quite large. They have very round nuclei. The cytoplasm is very basophilic, but it doesn't flow like that it does in the infectious mononucleosis, for example. They're quite large. And this is a patient who had viral hepatitis. And this is a patient, again, who's got a Turk cell. And that's the Turk cell, and I've photographed a small lymphocyte nucleus and put it next to it so you can see the difference. They stand out on the blood film very clearly. They're quite basophilic cytoplasm, an eccentrically placed nucleus, and a large cell. So you can call these Turk cells, or you can actually call them reactive lymphocytes. I might say reactive lymphocytes and then in brackets Turk cells, because they're a classical feature of dengue fever. And this is just another single, just to impress on you. This is a Turk cell or a reactive lymphocyte seen in dengue fever. Also seen in malaria infections as well. Often if somebody has got a significant number of malarial parasites infecting the red cells, these cells react. It's basically like a CD8 positive T cell reacting to an infection. And then in malaria, it's reacting to the presence of malarial parasites infecting the red cells. This is a case of varicella infection, chickenpox. And here's the Bordetella pertussis, which is a bacterial infection. And the classic feature in Bordetella pertussis is that the lymphocyte nuclei are cleaved. And not all of them will be cleaved, so it should be a significant feature. If you want to ask me the question, what percentage, I can't tell you. It's probably most classically found in a young child who will have a lymphocytosis for no known reason, except that when you get that lymphocytosis in a young child, I would look very carefully from field to field to see how many of the lymphocytes have got a cleaved nucleus. And when you see that, I would report it, definitely report it. And where I work, I make sure that the scientists will ring the consultant about this child and let them know that we've seen lymphocytes significant or commonly found in Bordetella pertussis. It's highly infectious, so it's important that you do notify somebody on the medical team looking after the child. And this is the last case. This is lymphocytosis of acute infection in a child. These were CD4 positive T cells, and this is probably the only case I have seen. You can see the T cells often do have cleaved nuclei. And this was a little child who was 3 years of age who had a very high lymphocyte count and had a very severely infected finger. And I watched this patient from progress. And after about 3 weeks, these all disappeared. But this is actually a recognized disorder, which is reported in some of the pediatric textbooks, and my only case that I've ever seen. So let's now go on to neoplastic lymphocytes. So neoplastic lymphocytes have many of the features of reactive lymphocytes, but they're part of a lymphoproliferative clone. They're almost always B cells, and they show B cell markers depending on their degree of immaturity. Of course, you do get T cell disorders, but they're T cell neoplasms, but they're much less common. So their cytoplasm, the B cells, their cytoplasm is contained, and it does not flow to the same extent as it does in the reactive lymphocytes. The cytoplasm is less basophilic, and the chromatin pattern of the nucleus is more coarse, and the nucleoli are more prominent. So B lymphocytes form a monomorphic population. There is a progressive increase in the number of neoplastic cells. They are associated with a concomitant cytopenia and/or a leukoerythroblastic blood picture. They show normal or hypogammaglobulinemia on serum EPG, and they may show a paraprotein. They're associated with non-tender splenomegaly and lymphadenopathy. So now I have listed for you all the B-cell lymphoid neoplasms, and these nomenclature will follow the latest WHO classification. So B lymphoblastic leukemia lymphoma, not otherwise specified, often shortened as ALL. Chronic lymphocytic leukemia, small lymphocytic lymphoma, which is shortened as CLL/SLL. Then there's pro-lymphocytic leukemia, splenic marginal zone lymphoma, hairy cell leukemia, lymphoplasmacytic lymphoma, and this is a more recent term for Waldenstrom macroglobulinemia, plasma cell myeloma. As I said, this is the more recent WHO classification, so we don't call it multiple myeloma is not used now. It's plasma cell myeloma, and then plasmacytoma, non-Hodgkin lymphoma, and Burkitt cell lymphoma leukemia. So the T cell neoplasms, T cell lymphoblastic leukemia, lymphoma, large granular lymphocytic leukemia, aggressive natural killer cell leukemia, adult T cell leukemia, lymphoma, prolymphocytic leukemia, cutaneous T cell lymphoma. So we'll go through that second group at the end of this workshop. We're now going to go through the B cell lymphoblastic neoplasms or precursor neoplasms. So we're going to talk now about B lymphoblastic leukemia/lymphoma, not otherwise specified. So the blasts range from those with a high NC ratio, fine to clumped chromatin pattern with scanty cytoplasm and inconspicuous nucleoli. Now, just to say to you at this point in time, some of you that may remember the FAB classification, the French, American, and British classification of these disorders. This first group here, was actually known as the ALL1, and the second group I'm just going to describe now, which is to those that are heterogeneous in size and shape, with fine to coarse chromatin pattern, often cleaved, indented, and folded nuclei. Nucleoli nearly always present with variability in size and number, and also a variable amount of cytoplasm. So if you're in the generation that used to know the FAB classification, this is the L2 group here. And what the WHO have done, they've linked the two together, just as a general description of the lymphoblasts that you see in B-cell lymphoblastic leukemia/lymphoma. And here's a really nice slide. This is showing you a case of B lymphoblastic leukemia lymphoma, and these would be the L1 type of lymphoblasts with a very high NC ratio, reasonably fine to clumpy chromatin pattern, basophilic cytoplasm, and in this case, inconspicuous nucleoli. Another one here, inconspicuous nucleoli. This is another, these two about the same. So they would be the L1s. These are a little bit different. This has happened to be a patient with a mixture. So possibly that's why the WHO have combined the two together. In these two here, these are classically lymphoblasts with a high NC ratio, slightly more fine chromatin pattern with a clear nucleolus. This is a nucleolus here and a nucleolus here. There's possibly one here, but they're usually described as being inconspicuous in this particular type of B lymphoblastic leukemia lymphoma, not otherwise specified. This is the bone marrow of the same patient, and you can see it's an overwhelming number, and this is very common in children. This is the classical bone marrow, which is filled with a very high lymph blast cell count, very high NC ratio, inconspicuous nucleoli, and something to note from experience that often when you've got a B lymphoblastic leukemia or even a T, you sometimes see vacuolated vacuoles appearing, even superimposing the nucleus, and it's a common feature that has no specific significance. Now I'm taking you through some trephines because I think it's very interesting to look at a trephine. Scientists may not look at the trephines, but you should make it your job to, if you see a case and you're looking at the marrow, just see if you can find the trephine and have a look at it. So basically, the trephine gives you the architecture of what's going on in the marrow. And they basically core down. After they've done the aspirate, they core down and take a cylinder of bone, and that trephine is sent to anatomical pathology, where it is decalcified and stained. And this is an H&E stain, hematoxylin and eosin stain. And this is part of the bone which has been decalcified. So when they've done that, they actually embed it in wax and they cut it on the microtome and stain it. So you can see here that we've got really a monomorphic population of cells which are just replacing the entire bone marrow. This is a slightly higher power. So that first one was times 200 magnification. This is times 400. And just to give you an idea that you've just got the marrow being replaced by a clonal population of lymphoblasts. So just to make it clear for you, because we call this disorder lymphoblastic leukemia/lymphoma. So the term B lymphoblastic leukemia applies when there is involvement of the bone marrow and peripheral blood, and the term lymphoblastic lymphoma when there is significant nodal or extranodal involvement, and the distinction between the two names is arbitrary. So now as I explained to you in some of the other workshops, These are morphology workshops, and I'm going to concentrate on the morphology features, but I obviously have to include the immunophenotyping of the cells and also the cytogenetics. So I'll just go through some of the markers and point out to you that these are B cells. So the B cell markers here are the CD10, CD19, 22, and I've already told you about CD34, which is a progenitor marker. So there are actually 4 different categories in the immunophenotyping, and they're actually grouped in. So this is called an early B-ALL. This is a common ALL, and they're grouped according to the actual maturation of the cells. The most common that we get, especially in children, is the precursor B-ALL, and you can see with the precursor B-ALL, the CD34 in this case, in that particular group, is negative. And then there's just a straight out B cell ALL, and that's all put into those categories according to the immunophenotype. Cytogenetics, we're not going to go into cytogenetics that much because it's not really, because if you really want to, if we were a registrar studying these workshops, you may want to know this, but these are just the most common cytogenetics. But I'm not going to go into those and explain those to you. So now we're moving to the next group, which is the mature B cell neoplasm. And we're going to look at chronic lymphocytic leukemia, small lymphocytic lymphoma, and classified, shortened often on the request form as CLL/SLL. And it occurs in older males with a median age of 65 years. There's a clonal lymphocytosis with more than 10 by 10 to the 9th per liter. You get small lymphocytes with round nuclei, clumped chromatin pattern, and basophilic cytoplasm. Sometimes you'll see smudge cells on a film with someone with this CLL/SLL. And just to make sure you understand, the smudge cell is these cells in this particular neoplasm are quite delicate, and when you spread them, even with when you make a manual blood film, but especially when the blood goes through the analyzer, you can produce a lot of smudge cells. It's just because they are fragile, and a smudge cell is really just a broken lymphocyte, and what you're looking at is the nucleus, which has been a little bit distorted. Less than 2% pro-lymphocytes are present in CLL. So it's not really even worthwhile reporting. You have to have more than 55% of pro-lymphocytes to put it into a pro-lymphocytic leukemia. So the occasional pro-lymphocytic cell is not really that significant in a CLL. And here's a classical picture of CLL, chronic lymphocytic leukemia. All of those lymphocytes look okay. They're nice, they're normal. I think when I probably started my workshops, doing the very first workshops, I emphasized on the fact that you look at the age of the patient and also look at the sex of the patient. Remember that CLL is a classic feature of older males. So you put it all together, it's all important. All these features, the clinical picture, it's all important to give you an understanding of what you're looking at. No point just reporting it and not knowing what you're looking at. That's not the idea of morphology. Morphology is very exciting, and when you put it all together, you can make a diagnosis yourself. So the CD markers are important in that when we go through all of these B cell neoplasms, CLL/SLL is the only one that is CD5 positive. And CD5 is a T cell marker, but it's positive. When we look at some of the others, which we're going to look at in this group, it might look a bit like CLL lymphocytes, if they're only going to be CLL if they're CD5 positive. Okay, so that's something to remember. Cytogenetics is a whole lot of cytogenetics. I'm not going to go into those. So now moving to Prolymphocytic leukemia. This occurs again in older males with a median age of 65 to 69. They have a clonal lymphocytosis, usually a very high count of more than 100 by 10 to the ninth per liter. The prolymphocytes must exceed 55% of the lymphoid cells in the peripheral blood to put it into this category, as I just said to you, prolymphocytic leukemia. Prolymphocytes are larger than the lymphocytes of CLL because the CLL lymphocytes are mature. Prolymphocytes are always just a little bit less mature and larger in size. They have abundant cytoplasm, a round nucleus with moderately condensed chromatin pattern. But what is standout feature of a prolymphocyte is they have a single large nucleolus. It's almost like an eye looking out at you. And this is the blood film of a patient with prolymphocytic leukemia. And I'll just point out to you the most classical of this film. They're all classical to me, but for you, if you're still studying morphology, that is just classical of a prolymphocyte. It's got a single nucleolus. The chromatin pattern is slightly clumpy, slightly immature. It is not a blast because the NC ratio is much too low. The NC ratio in a blast is very high, as you saw. So that's a classical prolymphocyte. This is another one here. There's a bit of a nucleolus here, which is not so obvious, but here, it's a really clear nucleolus here, here, and here. I'll show you another image of this patient. As I said, they have a very high white cell count, usually more than 100 by 10 to the ninth per liter. And here he has got a very high count. So he's gradually getting worse. This particular patient I remember very well because he was in his terminal stage of his disease and his white cell count kept going up. And so the hematologist looking after him leukapheresed him, took off some of the lymphocytes to bring down the count, and a few weeks later, sadly, the count went back up again. So that's a classical feature of prolymphocytic leukemia. Here's a single nucleolus here, 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 and here. Just like an eye looking out at you. And here's a smudge cell. Actually, these two are smudge cells, okay? I would only report smudge cells in someone who's got chronic CLL, but you do sometimes notice smudge cells. CLL is just a classic disorder, so not to mention smudge cells, but you can see the nucleus has been released from the cytoplasm. You can see the nucleolus there right on the edge, and these are two smudge cells. So that's what a smudge cell looks like, just a broken cell with a distorted nucleus. There's your immunophenotyping. Still looking at the B cells, but see, look, this is the CD5 here with the prolymphocytic leukemia, CD5 negative/positive, whereas in CLL, it's just straight CD5 positive. 19, 20, 22, 23, they're all B cell markers. And we're just going to disregard the cytogenetics. So now we're moving to the next disorder, which is splenic B-cell marginal zone lymphoma. And it occurs predominantly in males with a median age of 60 to 70 years. They have a splenomegaly or an enlarged spleen, and in some cases there's a lymphadenopathy and a hepatomegaly, so a large liver as well, and lots of lymph nodes. So the white cell count is usually raised, but it rarely exceeds 25 by 10 to the ninth per liter. So the lymphoma cells have a round to oval shaped nucleus, variable amounts of basophilic cytoplasm with thin, short villi, unevenly distributed and often concentrated to one pole of the cell. That's the differentiating feature morphologically. So what I've done here, I've shown you an image of a splenic marginal zone lymphoma cell. You can see that the nucleus is just slightly towards one periphery of that cell, and see the villi here towards one pole. And I'm just compared a normal small lymphocyte. So you can see the difference. And again, looking at the immunophenotyping, CD5 negative, okay. So now moving to hairy cell leukemia. Hairy cell leukemia is an indolent, so it doesn't, it's short, it responds reasonably very well to treatment these days. It's not such a frightful thing to have, put it that way. So it's an indolent neoplasm. It occurs more often in males than females. There's a ratio of 5:1 with a median age of about 50 years. There are two forms. The classical form presents with a pancytopenia, so all 3 cell lines reduced, including a neutropenia and a monocytopenia. And then the variant form presents with a mean white cell count of 88 by 10 to the 9th per liter, and it's not neutropenic or monocytopenic. I just want to talk about this 88. The latest books, the latest 2 WHO books go from, well, the 2 latest books talk about 30 to 35 by 10 to the 9th per liter. Some of these workshops have been going for a number of years, and this was one that was an earlier version of the WHO. But if you look up the WHO now, I think the second last one said 35 hairy cells by 10 to the 9th per liter, and the most recent one says 30. So just look at the difference in the actual morphology of these two types. So looking at the classical form, the cells vary in size from 10 to 20 microns in diameter. The cytoplasm is basophilic with many fine hair-like projections around the entire circumference, and the nucleus is eccentric and round to oval in shape. And the variant form, the cells are smaller with a diameter of 10 to 15 microns. Nucleus is generally centrally placed rather than eccentrically. And in both forms, the marrow is usually filled when you diagnose the patient with these hairy cells, but you can often see hairy cells in the peripheral blood as well. So the bone marrow shows patchy or diffuse infiltrate, and it may result in a dry tap. And I have explained that to you before, and I'll just revise that dry tap. The dry tap is when you can't aspirate because the marrow is just so full of cells that you just can't aspirate. So you get a dry tap. The trephine, which you would take a trephine if you had a dry tap, shows an infiltrate of lymphocyte nuclei, which is surrounded by halos of pale staining cytoplasm. And I'm going to show you a case of that later on, not in this workshop. I'm showing it to you in the case studies which are going to follow. And I've put it in for basically for the registrars because often they may be given an image of a classical hairy cell trephine, which is not that common, and it's very classically diagnosed. So I'll point that out to you when we do our case studies. So here we are. This is a hairy cell. This is the variant with a much higher white cell count. Okay, but these are, you can see that these are quite different where the villi are around the entire circumference of the cell, not like the splenic marginal zone lymphoma when it's to one pole of the cell. Now the classical and the variant can be differentiated as well by the immunophenotyping. You can see if you look at the CD103, in the classical it's positive, and in the variant it's positive/negative. And in CD25, In the classical, it's positive, and CD25 in the variant is negative. I'm skipping the cytogenetics, but anyone who wants them, it's all there. All, I'd say all, the most specific findings are there. So now let's look at the lymphoplasmacytic lymphoma, or I still remember it as being Waldenstrom macroglobulin anemia, and it's a subset. Waldenstrom macroglobulin anemia is a subset of the lymphoplasmacytic lymphoma. Recently changed the nomenclature, and when we look at the morphology, you'll understand why they changed it to lymphoplasmacytic lymphoma. It occurs mainly in males with a median age of 60 years. They have a normochromic normocytic anemia. They also have a monoclonal IgM causing hyperviscosity, so they often have a very high ESR, erythrocyte sedimentation rate, and they may have cryoglobulins present. So there's an increase in the number of lymphoplasmacytoid lymphocytes in the marrow, and sometimes you'll see those on the peripheral blood. The lymphocytes are small, with a round, sometimes eccentrically placed nucleus and basophilic cytoplasm. Often this is a bit hard to recognize, so you just, I guess how I can tell you how to do this is to just keep going over these workshops over and over. And looking at age of the patient, the sex of the patient, any history that you can get. In this particular disorder, the lymphoplasmacytic, you'll get a raised ESR. So this is a times 1,000 magnification, and normally I would not take a photo where the red cells were sort of forming a bit of rouleau. Rouleau shows up very strongly on times 10 magnification, but this makes me think when I see this sort of picture with the red cells, and I see that these are slightly lymphoplasmacytoid, looking a bit like a plasma cell, but they're not, and that's why it's being called lymphoplasmacytic lymphoma. This is a better one. This is a more on the same film. This was quite an advanced case of lymphoplasmacytic lymphoma. See how they're all slightly eccentrically placed in the cytoplasm. So much more easily recognized in this particular blood film. Again, I'm just emphasizing this is CD5 negative. And then these are the cytogenetics. So now let's look at plasma cell myeloma. So proliferation of plasma cells within the bone marrow, secreting abnormal amounts of monoclonal immunoglobulin, M protein or paraprotein in the serum and in the urine. And in the urine, it's called a Bence-Jones protein. So it can be an IgA, an IgG. Rarely, it could be an IgD or an IgE. And it occurs most commonly in males between 60 and 70 years of age. And one of the classical features that they get is bone pain. Sometimes they present with pathological fractures. So when I see an elderly male with perhaps a low hemoglobin and the history saying bone pain, I'm going to look very carefully for rouleau, because that's the classical feature that I see on the blood film. The pathological fracture is because these cells do penetrate into the bones, and so the bones become weakened. And a pathological fracture is somebody that actually doesn't put much weight on perhaps their arm or their leg, perhaps, and fractures their femur. Let's just say their feet. Forget the arm, but just pathological fracture without any effort, they fractured a bone. That's a classical feature of this disorder. So they have a normochromic normocytic anemia, never raised DSR, very important to raise DSR. Depending on where they aspirate, they can have between 10 and 100% plasma cells in the bone marrow, so it's a very patchy disease. Plasma cell leukemia is usually the terminal stage of plasma cell myeloma. And to have plasma cell leukemia, you have to have more than 2 by 10 to the 9th plasma cells in the peripheral blood. So these plasma cells have round, eccentrically placed nuclei, intensely basophilic cytoplasm, and a perinuclear halo representing the Golgi zone. And this is a classical plasma cell in plasma cell myeloma. So it's an eccentrically placed nucleus with a very basophilic cytoplasm, and that's the perinuclear halo or the Golgi zone. This is another plasma cell here, and I put this cell here just to show you this is a small lymphocyte. It possibly could be even a large lymphocyte because it's got a few granules in the cytoplasm. But just the difference between the plasma cell and the lymphocyte. This is a plasma cell leukemia, so this is a terminal disease, terminal stage of the disease. These are not so classical, but I want to point out to you that nothing's black and white in hematology. So you put everything together, all the information you can find, and work out what's going on. If somebody had plasma cell leukemia, I'm sure you'd have in the clinical notes that the patient started off with plasma cell myeloma. See how they're eccentrically placed, all of them eccentrically placed. The perinuclear halo are not showing so significantly on this particular blood film. This is the immunophenotyping, and there are some markers which I think stand out, which I try to remember. So CD38 is a classical marker for plasma cells, as is CD79A, and these are both positive. So there are certain markers that I remember because I'm actually not a flow cytometrist. I'm obviously a morphologist. Lots of cytogenetics, possibly. So now this is interesting. This is a solitary plasmacytoma of the bone. Now you remember in the myeloid cells when we talked about a myeloid sarcoma, this is the same sort of thing happening in the B cells, a plasmacytoma. So it's a solitary tumor of plasma cells identical to those that occur in plasma cell myeloma. They show up on X-ray in areas such as the vertebrae, the ribs, and the skull. And the immunophenotyping and the cytogenetics are identical to those of plasma cell myeloma. Now, occasionally I put some interesting slides in for you, not to confuse you, but this was a CSF on a patient who had a plasmacytoma. It was a very well collected CSF because there's only one red cell there, okay? And looking at these without knowing anything about the patient, you'd be a bit confused as to what was going on. But if you do it and follow the way I teach you, you look at the age of the patient, you'll look at the clinical notes, which hopefully you will have someone has put into your patient notes that they had myeloma or plasma cell myeloma. Then you can tell that this is a really severe terminal stage of, this could either be plasma cell myeloma or a plasmacytoma, because as I said, they mark identically. Now we're moving to the lymphomas. So this is non-Hodgkin lymphoma. These are malignant cells found only occasionally in the peripheral blood. The lymphoid cells may be large with a high NC ratio, a non-cleaved nucleus and prominent nucleoli, or smaller with more basophilic cytoplasm and a cleaved nucleus. So these are classical lymphoma cells in a patient who has got mantle cell lymphoma. There's lots of different types of lymphomas, and if you're a real expert, you can tell the difference on the peripheral blood, but you don't necessarily have to be. What we have to be is to be able to recognize these as lymphoma cells because they do have a high NC ratio. You can see the cytoplasm there. There's a bit of cytoplasm here, all right? But you need to be able to recognize that the chromatin pattern is mature. It's not immature like a blast cell, and the nucleoli, in this case, are not obvious. So these are mature cells with a high NC ratio, and these should be counted as lymphoma cells. This is another case of mantle cell lymphoma. Morphologically, a little different. This looks like a very angry case to me, but this is also in the bone marrow as well, with a high NC ratio. But you wouldn't want to call this a blasted cell because it's so mature. This is so mature. This one is a touch immature. It's got a nucleolus there, but you need to move from field to field and get a general feeling of the cells. And this is another patient, a poor patient. This is the acidic fluid of somebody who had mantle cell lymphoma. And this is a terminal stage of the disorder. Just to give you an idea, we look at a lot of blood fluids where I work. Sometimes it can get a bit overpowering, so many fluids, but this is a patient who's got acidic or ascites and terminal stage of mantle cell lymphoma. This is a follicular lymphoma. Follicular lymphomas tend to be just slightly convoluted, slightly not but still lymphoma cells. We don't need to be able to recognize the difference. I must say that if you bought lymphoma cells with a QAP and don't, I'm talking about in Australia, the Royal College of Pathologists Quality Assurance Program. I'll just start again. If you say lymphoma, you will score of 4, because I was a referee for the QAP for a long time. Things that I'm not so sure about the way the QAP in Australia mark or score the lymphoma cases. Here's another lymphoma. This is a diffuse large B-cell lymphoma. Okay, this is a very angry lymphoma. These are lymphoma cells. So you can see the nucleolus there. This one's got a nucleolus here, probably a couple of nucleoli. This one's a tiny little bit squashed, but this is diffuse large B-cell lymphoma. Another case of diffuse large B-cell lymphoma. I couldn't find any cells that looked so beautiful as peripheral blood. Okay, so now we've got these are the markers. So this is actually a mold lymphoma. I'm just going to go back to another slide. Yeah, okay. So we've just skipped to mold lymphoma. I haven't got an image of a mold lymphoma. But these are the immunophenotyping. Here you can see, again, CD5 negative. I'm just going over the immunophenotyping. Here's the follicular lymphoma as well. These are the markers, the immunophenotyping. The mantle cell lymphoma and the diffuse large B-cell lymphoma. None of them have got CD5 positive. So often when the doctors diagnose these cases, they just call them B-cell lymphoid disorders. It's not till you see the actual markers that you can actually put it into the right category. We'll skip the cytogenetics. So now Burkitt's lymphoma. It's a highly aggressive B-cell malignancy occurring in both children and adults. The cells are large, heterogeneous blasts. They have round nuclei with finely stippled nucleochromatin pattern and one or more nucleoli. They have intensely basophilic cytoplasm, and these cells stand out because they have prominent vacuolation in this intensely basophilic cytoplasm. Lymphoblasts are confined to the nodal or extranodal sites. If that's the case, it's diagnosed as a Burkitt lymphoma. So if the lymphoblasts invade the bone marrow and spill over into the peripheral blood, then it's called a Burkitt cell leukemia. The latest WHO classification is Burkitt leukemia variant. They keep changing nomenclature. I would just call this a Burkitt cell leukemia. And the image I'm going to show you is a Burkitt leukemia. They now call it a Burkitt variant. You can see here it's a Burkitt variant. These are the classical Burkitt cell leukemia in the peripheral blood. You can see the nucleoli are quite often not that obvious. There's such a lot going on. There's vacuoles in the cytoplasm, and actually vacuoles can overlie the nucleus as well. And just for fun, I once gave a case of this to anatomical pathology and asked them to do an oil red O stain for me on the case because I wanted to know what was in the vacuoles, and I'll just tell you it's lipid. Was it stained up positive for oil red O? So again, this is the immunophenotyping markers here, CD5 negative, and cytogenetics. So we've gone through all the B cells, and the B cells are the most common that we see. T cells are much more rare, and I think having a T cell neoplasm slightly less, a lesser prognosis, not so good. So let's look at T lymphoblastic leukemia lymphoma, not otherwise specified. So the blasts are small to medium in size with a high NC ratio. They have moderately condensed chromatin pattern and inconspicuous nucleoli. The nuclei are often folded and cleaved. So T-cell acute lymphoblastic leukemia occurs most commonly in adolescents rather than in young children. So basically the features are much the same as the B cell, but you do get these cleaved, folded nuclei. And I guess it's a bit sad that it's more the older adolescent children. And it's a hospital where I work here in Sydney, Australia. They have a separate oncologist, a separate pediatric oncologist who looks after the adolescents. So looking at the peripheral blood, you can see, if you can think in your mind back to the B cell peripheral blood, I think we only had about 6 blast cells on that picture, but the total lymphocyte count or lymphoblast count on the T cells is very high. They have a very high blast cell count. You can see, I've tried to show you some of the nuclei are cleaved. So there's a cleft there in this cell here. There's a cleft here in this blast. So these are all blasts with a high MC ratio. This cell here is probably cleaved as well. So That's a classical feature. There's another bit of a cleft here, I think, as well. And as I said, you can sometimes see vacuoles, so you can see that in the T cells as well. Not so many in this particular case. This is the marrow, but there are some more vacuoles in this one, in the bone marrow. And these are classical, this is a classical T lymphoblastic leukemia / lymphoma. We see some cleaved, that looks a bit cleaved here. I would never actually admit to a doctor, even if I thought I had the right diagnosis, that I thought this was a T cell, because you need to make sure you never report, you just report these as being blasts. You never report that these could be T cells. If the parent of a child ever got to read a report that said suggestive of a T cell ALL, if they looked that up on Google, they'd know that it had a very poor prognosis. So that would be something that you would never do. And just reiterating again that the term T lymphoblastic leukemia applies when there's involvement of the peripheral blood and bone marrow, and T lymphoblastic lymphoma when there is significant nodal or extranodal involvement. And the terms, the distinction between the two terms or names is arbitrary. Now, as I told you when I was talking about some of the other myeloid disorders, that the WHO book still talks about cytochemistry. So I have shown you some cytochemistry in this particular T cell leukemia, something that we don't do anymore. But the actual, according to the WHO, the T cell lymphoblasts show focal positivity with acid phosphatase stain, and you can pick that on the peripheral blood and bone marrow. And these are the T cell markers, so they're easy to remember. 2, 3, 4, 5, 6, and 7, and 8. So they're the markers on this particular case. Lots of cytogenetic possibilities. And I have shown you an acid phosphatase. It's quite an old slide, but this is what we used to do before we had the immunophenotyping. So this is the acid phosphatase showing you the focal positivity. So this is a bone marrow slide, and we've treated it with acid phosphatase. And so this is the way we used to pick. This is a T cell leukemia. Now we've got much more precise markers. I put this in for interest again. This is a T lymphoblastic lymphoma in the CSF. This is actually a beautiful, I shouldn't say this, but morphologists do talk about terrible disorders being beautiful to look at. So this is a beautifully collected CSF, again with no red cells. These were T lymphoblasts with a high NC ratio. The nucleoli are really very prominent. There's a prominent one there and there and there. They're very obvious. You can see them everywhere. And they are T cells, so you do see some sort of, you can see cleaved, and you get an idea that there's some that are a bit cleaved. Not quite as good as I thought it might be, but a classical CSF. So CNS relapse probably in this particular case. Now, little boys can relapse. So I'm talking about the T cell, and in the adolescence as well, they can relapse in the testicle. And so this is a case of a testicular relapse in a little boy. And this is a biopsy which has been taken and stained with the hematoxylin and eosin stain in anatomical pathology. So I'm just going to go onto a higher power to show you. This is under 100 oil immersion, and you can see clearly with H&E stain that these are blast cells. You can see the nucleoli standing out very prominently, and these are blasts. So this was a boy, he was an adolescent who had T-cell ALL and sadly relapsed. Now, if it was again a case of unable to get a trophine to make a diagnosis, or you wanted a quick diagnosis from that biopsy taken initially, if you did an imprint of that biopsy onto a glass slide, so this is the actual testicle tissue which has been just touch prep onto a glass slide, and you give it to the hematology department, they'll do a Romanowski stain for you and prove to you in a short period of time that these cells are lymphoblasts. You can see this one's cleaved, starting to be cleaved, and it's starting to show a bit of a cleft here as well. So now moving to the T-cell prolymphocytic leukemias. Again, just like the Bs commonly seen in elderly males. Again, the white cell count very high, more than 100 by 10 to the 9th per liter. The lymphocytes are small to medium-sized with non-granular basophilic cytoplasm, round to oval-shaped nuclei, sometimes clover leaf shaped with a single nucleolus. And again, I'm just taking it from the WHO, stained positively with acid phosphatase. So this is quite rare. And these are showing you the clover leaf shape of the nucleus. There's a nucleolus there. There's possibly a nucleolus here. And one here. And even one here. But this is a T cell. And again, this is another case. Beautiful nucleolus there. With a cleaved nuclei here. Cleaved, couple of clefts here. The nucleolus here. Nucleolus here. T-cell markers. And cytogenetics. So now some of the really, really rare ones. I don't have examples of all of these. So this is a T-cell large granular lymphocytic leukemia, commonly shortened as an LGL. It's a clonal proliferation of CD3 positive large granular lymphocytes, afflicting older males and females with equal frequency. They have a lymphocytosis between 2 and 20 by 10 to the 9th per liter. They're severely neutropenic with less than 0.5 by 10 to the 9th neutrophils, and often they have a positive direct antiglobulin test. So they have a hemolytic anemia. So not all cases of T-cell LGL have increased absolute lymphocyte counts. So careful observation of the blood film is necessary for a diagnosis of this neoplasm. They have a very indolent clinical course. They can go on for a long time, and 30% of cases will have rheumatoid arthritis. The lymphocytes are large with abundant basophilic cytoplasm containing fine to coarse eosinophilic granules. The nucleus is round to oval in shape, and smudge cells, interestingly, are not a feature of this neoplasm. And here I do have a really nice example to show you these large granular lymphocytes. You can see the granules in most of these. Here's the immunophenotyping and cytogenetics, no specific cytogenetic abnormality. So now looking at the aggressive natural killer cell leukemia. It occurs in teenagers and young adults, both male and female. They have large granular lymphocytes with basophilic cytoplasm containing fine to coarse eosinophilic granules. It's a very aggressive disorder, and the patient can die within days or weeks. Unfortunately, I have not an image, I have not seen a case, so it's very rare. Thank goodness it's very rare. Here's the immunophenotyping markers, and often not many cytogenetic markers. If it's present, then this is the most common disorder. So now moving on to the next one. This is adult T-cell leukemia lymphoma. So less than 5% of cases of CLL/SLL are ATLL. Diffuse marrow infiltration, cutaneous tumor involvement has characterized this ATLL. Is caused by the human T-cell leukemia virus type 1, the HTLV1. And they have an absolute lymphocyte count which is higher than that in CLL/SLL. In most cases, the lymphocytes are morphologically indistinguishable from those of CLL/SLL. However, in some cases show characteristic convolutions of the T cells. I think you have to use your imagination, but that's possibly, this is what you're going to see. Slightly indented. This is the immunophenotyping and the cytogenetics. So now moving to cutaneous T-cell lymphoma. And of course, cutaneous means referring to the skin. So this occurs mostly in males over 50 years of age. Some T-cell lymphomas are associated with the HTLV1 retrovirus. Sézary syndrome and mycosis fungoides are both T-cell lymphomas and have a predisposition for the skin. So you get skin lesions with severe itching. The lesions develop into plaques, which in time develop into cutaneous tumors, and you get generalized exfoliative erythroderma. So Sézary cells may be either large or small with a high NC ratio. They have they have round to oval nucleus with condensed chromatin pattern with a characteristic hyperconvoluted or cerebroform appearance. Now it's quite difficult to photograph Sézary cells. This is the best that I could do. And if you look at this cell, look at it carefully and move from field to field when you're trying to work out what a cell really looks like. Move from field to field and look at the friends that it's keeping. But you can tell that there's something not normal about that nucleus. With a bit of imagination, you can see that there are convolutions going through that chromatin pattern. And here's another example, slightly different angle. You can see that there are convolutions going through. So this was a patient that was classically had Sézary syndrome, and I tried to do the best to get really nice looking Sézary cells for you. Now again, because I often have registrars doing my face-to-face workshops, this was just a slide for the registrars, something a bit informative that to differentiate between Sézary syndrome and mycosis fungoides. So in Sézary syndrome, You get 1 by 10 to the 9th per litre Sézary cells in the peripheral blood, and the CD4 to CD8 ratio is more than 10 to 1. And in mycosis fungoides, less than 1 by 10 to the 9th per litre Sézary cells in the peripheral blood, and the CD4 to CD8 ratio is less than 10 to 1. And sometimes we're asked to look for Sézary cells on a blood film. They might be querying mycosis fungoides, and that's what you've got to look for. So to differentiate between the two, Sézary syndrome and mycosis fungoides, best done with immunophenotyping. You can see that when you come to CD7 in the Sézary syndrome is positive/negative, where it's negative in mycosis fungoides. And yeah, these are both negative, CD8 are both negative. So you really need to look at your CD7 to differentiate 100%. These are the cytogenetics, but no specific cytogenetic finding has been identified in Sézary syndrome. And again, the same in mycosis fungoides. So you're basically looking at your immunophenotyping. And so that ends the session on lymphocytes.